My name is Jessica Stone. I'm the program director for Janus of Santa Cruz. I've been there for about 10 years. I worked primarily with pregnant and postpartum substance abusing women for 8 years of that. And now I also oversee the sub-Q detox and the outpatient and residential programs that are also co-ed and for the co-occurring disorder group as well. So I have all my notes, hold on. I just want to, can we go back to the original image real quick? I was searching the internet for images of wellness, and there were all these really cool things that came up, and what happened for me is I started looking for my own pictures, and this is my daughter, and that image to me like really embodied this idea of freedom, this idea. Sorry, better? Okay. I'm trying to talk slow. I'm kind of a fast-paced person, slowing it down, so I get quieter. Just give me hand signals. Anyways, this embodies freedom to me, possibility, and honestly wellness. That's what I saw when I saw that picture. So that's why I put that up there. Imagination, wonder, everything that I hope that our clients would get from working with us is this possibility to get in touch with that person again. And so, okay, now we can go. So I just want to start with a basic definition of co-occurring disorder. It's the coexistence of both a mental illness and a substance use disorder. There doesn't have to be a specified combination in order for somebody to meet criteria. It can include two, one mental illness, one substance use disorder, or more. You might have 4, 5, 6, or 7. Some people use the term COD as a shortened version, or dual diagnosis has been used quite a bit. It's a more broad term than co-occurring. Co-occurring is specific to substance abuse and mental illness, where dual diagnosis can be other health disorders. So just important statistical fact on the next slide is that roughly 50% of adults with serious mental illness also have a substance use disorder. That's a lot of the people we see. And so instead of it where it used to be kind of the exception, it is now the rule. It is who we're working with, who we're seeing, and they meet criteria for both. Just adding to their stigma. And I just wanted to briefly just talk about the neurobiology of addiction real quick. I'm sure a lot of people know a lot about this. There's a couple different theories that I think are great to share. One is the hijacked brain theory, where the brain is literally hijacked by the nucleus accumbens, which is our pleasure reward center, meaning it feels good, do it again. It doesn't feel good, don't do it. And the first part of our brain to stop working really is our prefrontal cortex that says maybe you should think about this before you use a substance. So unfortunately also leads to our flight or fight also getting involved, saying I need this to survive. It is also a mental disorder, and I think there's a lot of people that put it in a separate box and don't want to talk about it as a brain disease. And the added stigma is there. For those that don't know, more women die from substance use disorder related illness than from breast cancer. But you don't see any walks or marches or anything for that group of people. And so I definitely come from the model of working mostly with women, and working with the co-ed population really introduced me to a whole new realm of co-occurring disorders. Because mostly with women we are seeing postpartum depression, depression and anxiety. We're now at the primary facility, we see a lot more schizophrenia, bipolar. In the men, definitely more of that going on. And I have to say, when I think of stigma, if you've ever worked with a woman that just had a baby and is in postpartum depression and early recovery and used to cope with that the people in the universe don't really think very highly of her in that moment. And they certainly don't look at her like she has a brain disease. They look at her like a bad mom, a bad person, an inept mom, all of those different things. And the reality is her brain's not fully functioning. So the other thing that I love, and it comes from a parenting study, there's a really, really fabulous book where do I have my information on it? I wrote it down for myself. It's from Parenting on the Inside Out, and so for anybody who knows about positive parenting or positive discipline, they talk about it, but they do the brain in the palm of your hand. Has anybody here seen that? Does anybody know what that is? Okay, it's a really nice, I have the link to the website if you want it. It's a nice image of what it looks like for somebody with brain, as their brain develops. They use it for working with children, because the prefrontal cortex that's telling you to think things through doesn't really develop until your 20s. And so with kids, they're running around with their lid literally flipped. And so often our clients are running around the same way. The people we're working with, those with substance use disorders, especially those with co-occurring disorders, are running around the same way, like this, their lid's flipped to the universe. And so, so we have a lot of work to kind of parent them at this level, recognizing that that basic skills are super important. Learning how to sit through an uncomfortable situation without doing something that's not safe is super important. Really fundamental stuff. There's an actual image of this, the lid flipping on the prenatatoparenting.com website. And it's just a nice website to look at the image and how it explains it. This is another way that we look at trauma in the brain and how trauma impacts our flight or fight response, and the people's lids flipped. I put the ACE study up here because we also know that trauma impacts the brain and it impacts addiction at a staggering rate as well. And I noticed that MHCAN has the actual ACE handout at their table, which if you're curious more about that study, there's a lot of information about what happens in the first 18 years of life and what that means for your health outcomes later. Included in that as addiction and ultimately early death. So I just wanted to put that on there. How am I on time?
You're at 7 minutes.
Great. Okay, so just want to talk a little bit on the next slide about the history of alcohol and drug treatment versus the needs of co-occurring population that we're seeing today. So history, a lot of 12-step approach. You go into a treatment center and you're required to attend 12-step meetings. Often you're required to get a 12-step sponsor who might be fully abstinence-based that says, no, you can't take your medication, even if you need it, because that means you're not quote-unquote clean. And so the 12-step approach, TC model, the therapeutic community, some people know about the Synanon and how that all started. Very confrontational. You're in denial, you're in non-compliance, you're not listening, you're, all these very judgmental, confrontational. I need to tell you what's wrong with you so that you will fix it. And I have no doubt that people with substance use disorders and mental health issues know that there's something wrong. And we don't need to tell them in order for them to recognize that. Hey, you shouldn't use because this will happen. They know that. Ask them, what will happen if you use? They will tell you. These things will happen. That does not stop them from using. Unfortunately, if that worked, we'd all wear our seatbelts every day. You know what I mean? We're not really preventive in that way. The other pieces, there used to be this thing called the hot seat that also came on out of the Synanon, which is somebody sits in the middle of the room and everybody in the group tells them everything that's wrong with them. This idea of break you down to build you up. For those that don't know who William Miller is, he's the co-author of Motivational Interviewing. So when we look at the needs today, there is a really fabulous article that he wrote with William White. And I also have the link to that if you want it, but it talks about the lack of scientific evidence that confrontational therapy works with this population, that there is no evidence, none, in 4 decades of trying to get evidence that this population needs confrontation to know what works. There is evidence, however, that there's groups of people that are more subject to harm from this, and those are the vulnerable populations that we work with. And so that actually, instead of helping them, we're harming them, and that there is evidence of that. So today's needs, really looking at the integrated treatment and what that really is, which means that higher skilled staff, cross-trained staff. I want to say for myself, you're welcome at any time to come to Janus and say, hey, can I have a tour facility, meet your counselors, understand what you do, so that I can better refer my clients. So that you can walk them over and say, you know what, I met that counselor, I know who she is. And then maybe that safe handoff is there. the alternatives to 12-step. There's Dharma Punks, which is refuge recovery, which is meditation-based. There's Dual Recovery Anonymous. There's Smart Recovery. There is just support groups in general. MHCAN has a grip of support groups that are fabulous. There's Seeking Safety. Walnut Avenue does Seeking Safety groups. There's a lot of different options. Flexibility in addressing cross addictions. I know we've been talking a lot about sugar. There's a direct correlation between alcoholism and sugar, and that many of our people switch from self-medicating with drugs and alcohol to self-medicating with food. And sugar is just as responsive to that addictive part of our brain, and it can look very similar. So you've got a lot of people that, there's a saying that people put down the spoon and pick up the fork, implying that they, that this is their new addiction. I just put the next slide in because I think that's what this requires. Not saying we can all do the splits. Am saying that many of us feel like we're doing the splits and trying to serve the population that we are, and that we're having to get more and more flexible and creative and coordinated with our care. So just some basic ideas for improvement, some things that we're doing at Janus, but also some things that are new to some of our agencies. Because I can tell you just in the last 10 years that I have seen it be progressive to even have a conversation with a client who may have postpartum depression in a perinatal treatment center. And that nobody did that for years until about 4.5 years ago. And that for a long time, if you took medications, you couldn't bring them into treatment. And that is just changing now. And there are still programs in this county where you can't take your medications. And if you do, then you're non-compliant. Or if you don't take your medications because they don't feel good, then you're non-compliant. There's a lot of non-compliance going on. So some change in language that, often addictive behavior isn't very pretty. We don't really like it when people lie, steal, cheat, when they cuss at you, when they say not nice things, and that those are symptoms. Those are symptoms of addiction. Those are symptoms of co-occurring disorders. Those are not because they're bad people. They might come off not very nice, but that's not what's going on. Looking at level of motivation versus level of denial. This person's resistant. They're in denial. And that I have to show them that they're in denial, what they're in denial from. And so motivational interviewing has been transformative to this group of people. Trauma informed. The first time you send somebody who recently was assaulted to get a drug test and they have to pee in front of you, it's a pretty awkward situation for them. So having alternatives, mouth swabs. I can tell you that it really sucks to try to give a pee test to a woman that just had a baby. That part of your body doesn't want to be seen. And it just went through a lot. And so having options. So really looking at what is trauma-informed care. And I talked about not using those words. Also different options for treatment, gender-specific, co-occurring specific. We have a DBT skill-building outpatient group. We have a contract with Beacon now, so we're doing individual therapy because not everybody can do group. Shorter stays versus extended stays. We're waiting for a Medi-Cal waiver for residential because that will change everything. Right now, Medi-Cal is covering outpatient, but in residential, we might be able to keep people longer than 30 days in a short-term res. Maybe it'll be a longer program. The way we have with perinatal because of Medi-Cal. Perinatal, they're there for almost 6 months. The difference is massive. They get to get integrated into society. 30 days doesn't work enough. Particularly with the co-occurring population, they need more. They need more. Harm reduction versus abstinence. We have a lot of people that come in and they're not ready. They're not ready to give up drugs entirely, but they're ready to talk about it, and that's enough. And so having counselors that are willing to work on that. Offering seeking safety groups, just starting with the discussion about what's safe and what's not. Having humor. I have to say there's this really beautiful meditation called FUCK, that guided meditation. For those that haven't seen it, please look it up online. And for those that have, that for anybody that's never done meditation, or the idea of even sitting still and listening to somebody tell them how to relax is repulsive, this is perfect. Because it brings humor. It brings humor and it helps them lighten up a little bit. We offer grounding objects. We bring every kind of grounding object possible. When I know for myself, when I facilitate groups, you can sit, stand, you can stretch, you can have a grounding object, you can not, because not everybody can sit for the entire time, especially the addicted population. That doesn't feel good, especially if they're really anxious and they were self-medicating, especially if they're having some extra stimuli. Just holistic care in general. You know, we started, you know, we partner with a lot of agencies, and I can't tell you how many people are willing to give of their time if you're willing to give of yours. Acupuncture from Five Ranches comes and gives free acupuncture to our clients to reduce symptoms because we give them clients for their students. It's a perfect trade, and that those trades exist all over, you know, and that there's tons of options. Just the last slide, and something just to mention that we have here today is that I have this really fancy, beautiful scope kit right here. Does anybody not know what scope is? Okay. Scope is overdose prevention. Has anybody seen Pulp Fiction? There's this really intense scene where a girl gets stabbed in the chest and comes to life, and that's not really what happens, but it gives you a general idea of what this is. If somebody overdoses on opiates or opiate medication, heroin, that this is to reverse the opiate overdose. And these are given out free of charge to the community by Janus. You are required to get a training. It takes 15 minutes max. We have a bunch here today. It's donation based because we give them out free of charge to everybody. But if you have somebody who has a family member or who is currently using opiates or hanging out with people who are using opiates or on prescription pain meds, please come and get one because it can save a life, and overdose is preventable. And as it was stated earlier, our people die. Our people die from drug and alcohol addiction. They die from unsafe practices around needles, and they die from overdose. So this is available, and I just, I guess my biggest goal today is for people to know that addiction is also a brain disease. That I don't think anybody chooses to do that kind of stuff. That if anybody could choose otherwise, they probably would. And that please come and get these at the very end. In the back, Courtney will do a mini training for anybody that wants one, and you can walk away with one today. So, thank you.